Good afternoon. We will begin momentarily. Thank you for joining today's webinar, Differences in Clinical Outcomes Among Patients with Hypertrophic Cardiomyopathy in the All of Us Research Program. I'm Angela Balfour Franklin, Engagement Lead for the All of Us program at Community Campus Partnerships for Health. Together with RTI International, we welcome you to this webinar. Please feel free to use the chat to share your questions, comments, and reflections throughout the session. You'll be asked at the end of the session to fill out a survey. Your insights will be used to continue to help make programming decisions, so please take a few moments and fill out the survey. We want to hear from you. I would also like to make note of the fact that you are especially welcome today because today is the final webinar in the All of Us series. We started as the new direction in health research and equity seminar series, and we have moved to the All of Us webinar, and this is our final one. So thank you for joining us for today's session. Next slide, please. Quickly, we're going to go through the agenda. We've, of course, already welcomed you and told you to please use the chat. I'm going to tell you a little bit about Community Campus Partnerships for Health. Then we will have our first presentation by Dr. Sula Hood. We'll have a second presentation by Drs. Assad Bouyan and Dr. Precious Idet. We'll have Q&A after that and fireside chat. And we'll have the evaluation survey and closing remarks. Next slide, please. Who we are. Community Campus Partnerships for Health promotes health equity and social justice through partnerships between communities and academic institutions. We view health broadly as physical, mental, emotional, social, and spiritual well-being, and we emphasize partnership approaches to health that focus on changing the conditions and environments in which people live, work, study, pray, and play. Next slide. What we do. We help solve challenges like lack of trust between communities and institutions, unequal power dynamics in research partnerships, limited capacity for sustained community-engaged collaboration, and disconnects between public health research and real-world impact. Our focus areas are building and restoring equitable, trust-based partnerships, leading capacity-building efforts that strengthen community and academic collaboration, and supporting community-driven research, policy, and practice that leads to sustainable change. Next slide. CCPH's research team for the All of Us program includes our executive director, Al Richmond, as well as our production team with Keisha Vines and myself. Next slide. Right now, I would like to introduce Dr. Sula Hood, who will be presenting on the Research Academy and Workbench. Dr. Hood is a senior research scientist at RTI International, a nonprofit research institute. She has over 17 years of experience with a focus on health communication and community engagement in genomics. Dr. Hood is a co-investigator on RTI's All of Us Engagement and Retention Innovator Award, and she serves as co-lead for the All of Us Researcher Academy. Dr. Hood, welcome and thank you.
Thank you so much. And I'd just like to echo Angela's thanks as well to everyone who is attending today, this final webinar in the series. It's been a labor of love and an absolute pleasure working closely with our colleagues at CCPH, as well as all of the various different presenters that we've gotten to hear from over the past several months. All right. As Angela mentioned, I am the co-lead for the All of Us Researcher Academy. And I just want to flash my team here on the screen. We have many people who we work with that make the Researcher Academy happen. Next slide, please. All right. I'll just share a little bit about, to start, what the Researcher Academy is. But first, to ground you in what the All of Us Research Program is. The All of Us Research Program is a national initiative sponsored by NIH. And it is a historic effort to collect and study data from 1 million or more people across the United States for the purpose of enabling individualized healthcare and informing precision medicine. The goal is to learn about as many different types of people as possible so that we can be more precise in our approach to healthcare. Where the Researcher Academy fits in is that we are a program that provides training and technical assistance to researchers who are going to analyze the All of Us data. The way in which they analyze that data is with the All of Us Researcher Workbench, and that is a cloud-based platform that I'll talk about a little bit more in depth here shortly. Overall, networking is at the heart and center of the Researcher Academy, and we support peer-to-peer learning as well as network building among researchers within institutions and across institutions. Next slide, please. All right. As I mentioned, a primary goal of our Researcher Academy is to establish a large and sustainable network of researchers that utilize the All of Us data. And we really want to expand that network across the U.S. We do this by achieving several different objectives that I'll briefly walk through, and these tie into our various different program components. One of the things that we do through our academy is to engage with researchers and institutions to raise their awareness about the All of Us data set as a resource that they can use and to assess their needs such that we can help, if possible, to support them in analyzing data. We also offer internships, and so we've had a few cohorts of student internships, interns, as well as fellowships, where we work very closely with people in these cohorts and support them in learning how to use the researcher workbench that houses the data. We also have a very robust training curriculum that I'll touch on here shortly that offers a variety of topics and skills to enhance people's ability to use the researcher workbench. We have a team of individuals. We call them our researcher workbench coaches, and they provide direct technical assistance to researchers that are utilizing the researcher workbench. And then we also build partnerships with institutions and organizations across the country and work with them to learn from them and to share with them so that we collectively can achieve the goal of connecting people to the researcher workbench. And then finally, evaluation. We're always interested in learning how we can do better so that we can improve our delivery for people who are ultimately going to benefit from what we're doing. Next slide, please. All right. One of the program components that we're really proud of and that has made a tremendous impact in service of our mission and goals for the Researcher Academy is our Institutional Champion Award mechanism. And this is a funding mechanism that supports researchers in conducting research utilizing the All of Us data set. And so we support teams of researchers, including faculty faculty members, students, and postdocs. And each team receives up to $75,000 in funding to support their work that is going to be focused on all of us. We do promote the collection of individuals who are interdisciplinary in nature. And so our teams that we support may have someone in social work combined with someone over in the basic sciences, for example. And that's just reflective of the fact that the All of Us data set has so many different types of data that is relevant to researchers from a range of disciplines. Over the past several years, we have had the fortune of being able to support researchers in 4 different groups and a collective total of across 21 institutions. Next slide, please. Okay. So as I mentioned, one of the things that we have done as a part of our academy is to develop a curriculum. And we have also developed a course catalog where individuals can go and read about the different topics that our courses cover. And these courses are housed online and they are freely accessible, and there's no charge for utilizing these online courses and accessing these various different modules. But they cover a wide range of topics from Researcher Workbench 101 to certain analyses within R and Python to how to write a manuscript, how to disseminate your findings, how to do a literature review. So there's a wide range of course options. So I encourage everyone to please scan the QR code and check out our course catalog. And there's also a live link that will be available when the slides are shared out. Next slide, please. All right. Another resource that we have is our Academy newsletter, and this is the place where beyond these webinars, you'll be able to learn about any different types of program offerings that we will have through our Researcher Academy. We also use our newsletter to spotlight and feature research accomplishments of individuals that are affiliated with our Researcher Academy and to highlight all of the great work that they're doing in their work using the data set. So we have the QR code here for people to connect with the newsletter. Next slide. All right. So before we move on to our featured presenter for today, I do want to just cover the All of Us Researcher Workbench briefly and to tell you all about how you can get connected to it and a few of the features about the Researcher Workbench. Next slide, please. All right. So as I mentioned a few minutes ago, the All of Us Researcher Workbench is a cloud-based platform that houses all of us participant data. And so this is a secure platform, and this is where researchers are able to access the data and to analyze the data. In order to be able to access this data, individuals do need to go through a registration process. And so you can't just simply log onto the internet and access the data, but you actually have to go through a registration process. There are 2 levels or tiers of data that registered individuals can access. Individuals who sign up for the registered tier, they can access data such as information from electronic health records, survey data, more high-level data. Individuals who sign up for the controlled tier are able to access more sensitive data. And so this might be some genomic data or data where some of the demographics fields in the other tier have been suppressed. They'll have access to that information. I do want to point your attention over here to the right. As I mentioned, the All of Us data set is relevant and useful for researchers from many different disciplines, and there is a wealth of data. As you can see, there's over 600,000 survey responses from a range of different types of survey. There's physical measurements data, genetic data, data from electronic health records, wearables data, So just a wide range of data that's available. Next slide, please. All right. So when individuals go to sign up for the researcher workbench, they need to ensure that their organization that they or an institution that they're affiliated with has what's called a data use and registration agreement in place. And this is like an umbrella agreement at the institutional level. And so the way it works is that when you go sign up for the researcher workbench, your email address at your particular institution will be vetted or linked to your institution. And so if your institution has a Dura agreement in place, then you as an affiliated researcher with that institution will be able to go ahead and register. And so for institutions that do not have a Dura, no worries. Here's a QR code, and you can actually work with your institution to get that in place. Next slide. All right. So this is just a step-by-step process if you're new to the researcher workbench sign up. And so the first thing you'll do is confirm that your institution does have a Dura in place. If you click on the link here to the right or scan the QR code, will pop up. And there's a list of institutions. And so you can do a search to see if your institution has a Dura in place. Next, you'll create an account and verify your identity, and then you'll go through a mandatory training. And this is really around focus on the ethical use of the All of Us data, something similar to city training for those who might be familiar. And then finally, you'll sign a data user code of conduct. Just stating that you will properly use that data, and that is something that will need to be renewed on an annual basis for you to be considered an active user of the All of Us data. Next slide. Okay, and then finally, during your sign up process, it'll ask a few questions about how you learned about the researcher workbench. We would greatly appreciate if you are new to this and going to be signing up to have credit for introducing you to this great resource. And so you can select activity or presentation. And then also there'll be another follow-up question, and you can select All of Us Research Academy / RTI International, just to link us to how you found out about the resource and got led to the sign-up process. Okay, next slide. All right, so without further ado, I would like to pass it back over to you, Angela, for you to introduce today's speaker.
Thank you so much,
All
Dr.
right, thank you.
for explaining both the Academy as well as the Researcher Workbench. This afternoon's research project will be presented by two professors, the first of which is Dr. Precious Patrick Edet. Dr. Edet is an epidemiologist dedicated to advancing HIV and substance use prevention among at-risk populations. She holds a Doctor of Medicine degree from Poznan University of Medical Sciences, a Master of Public Health degree in Health Education and Promotion from the University of Southern Mississippi, and a Doctor of Public Health degree in Epidemiology from Jackson State University. Dr. Edet currently serves as a postdoctoral scholar at the University of Mississippi and a research fellow at Brown University. With a multidisciplinary background bridging clinical medicine, health education, and epidemiological research, Dr. Edet contributes to data-driven policies and interventions aimed at reducing health disparities in Mississippi and across the United States. The second presenter will be Dr. Azad Bhuiyan. Dr. Bhuiyan is a professor in the Department of Epidemiology and Biostatistics, School of Public Health at Jackson State University. His academic background includes a PhD and MPH from Tulane University School of Public Health and Tropical Medicine, where he majored in epidemiology and minored in biostatistics. Dr. Bouillon's research career started with the Bogalusa Heart Study. And additionally, his background includes a medical degree and practice in Bangladesh, showing a diverse and global perspective in his approach to public health. Please welcome Dr. Idet.
Hello, everyone. Can you all hear me? Yes, wonderful. Thank you all for making all the time to attend this presentation. It is an absolute pleasure to be here. Next slide, please. All right, before we delve into the study details, here is the outline. First, we'll begin with the background and then the objectives, the research methods that we conducted, statistical analysis, the results, the discussion, the conclusion, and then lastly, the acknowledgement. Next slide, please. All right, so first we'll start with the background. Hypertrophic cardiomyopathy, also known as HCM, is a genetic health condition that's marked by the abnormal thickening of the heart muscle. What makes this disease particularly serious is that the thickening often affects only specific parts of the heart, typically the left ventricle, which can worsen over time if it's left untreated. The thickened heart muscle can make it difficult for the blood to leave the heart. And so as a result, the heart has to work harder to pump the blood throughout the body. In addition to impairing blood flow, HCM can also reduce the heart's ability to relax and properly feel the blood between heartbeats. Next slide, please. HCM remains a complex and multifaceted disease, both here in the US and globally. What makes HCM especially challenging is its wide range of clinical presentations. Some individuals may experience only mild symptoms, while others can face serious complications, such as heart failure, irregular heart rhythms, also known as arrhythmias, and in severe cases, even sudden cardiac death. Because HCM is a genetic condition, it can progress over time if it's left untreated, as I mentioned earlier. And this makes early diagnosis and management very critical. Also, HCM is not rare. It is actually one of the most common genetic heart disorders, affecting approximately 1 in every 500 individuals in the US. Next slide, please. Despite its high prevalence, HCM is frequently undiagnosed. And this presents significant challenges for healthcare providers, particularly when it comes to early detection and timely intervention, both of which are very critical for preventing serious complications. Adding to this challenge is the fact that health disparities related to HCM, especially differences in how the disease manifests and how clinical care is delivered across different populations, remains poorly understood and poorly under-researched. This gap highlights the urgent need for more inclusive research and greater awareness among clinicians to help ensure equitable diagnosis and treatment for all patients that are affected by HCM. Over to you, Dr. Boyan. You are muted if you want to.
Thank you. So, yeah. So therefore, that's why we try to investigate this, the association between ethnicity, race, and along with the social determinants of health, and also looking at the clinical characteristics and also the patient care using all of us data. So next slide, please. So research methods, we use all of us, it's called All of Us Research Workbench, and it is initiated by National Institute of Health. And it has include, actually why it's so popular, because it include diverse population and and also initiative to develop a precision medicine approach for every individual in the United States. And I know this number is last night I saw is now is around 770,000 participants consented to join the program. So it increased because I did this analysis last year. And researchers have access to all of us research program. Here, I think Sula would already mention to Workbench login after completion of all of us research responsible conduct of research training. Once you completed this training, and then you can easily have access both registered tier and also the control tier. Even if you don't have access, want to go through research training, you have also have option just to look at using data browser and snapshot. That also can have the idea whether when you try to do research, you can have it. You can, before going to register, you can also look at the that research topic is there or not. Then you can log in there too. Next slide. So according to last year, I think when I use it, it's a data, it's called version 7 dataset. I saw this morning now from this year, I think it's February 2025, they release version 8. So maybe I need to modify before publication. So it has a number and everything is changed. So I used last year, it's called data, and also mostly for this research, we use EHR data, electronic health record data, and also merge with the survey data. Though that's showing how many survey responded, how many physical measurement data there. Also, my plan is also in future using genotyping data, whole genome sequencing data, and also survey data. So that way you can look wider aspect of that topics. Okay, next slide. So EHR data, when used retrospectively, develop a testable hypothesis from all of us research program, which has last year it was 287,000 EHR data across the US, and it has that's a beauty is that 45% of the participants from racial ethnic minority groups. So that is very important. So that's why all of us is very popular. And also when we always use de-identified data, so that way you can protect participants. Next slide. For this it's called hypertensive cardiomyopathy. For this one, we got 11,132 patients, and also we use only two race, black and white, and we exclude other race ethnicity group. And for clinical variables, were extracted using EHR data. Like they have a lot of people know that ICD-10 and ICD-9 code, and there is another, it's called SNOMED concept ID. That's a standardized code. So that's why we use both SNOMED concept ID, ICD-10. When you don't find ICD-10, we also try to look at ICD-9 code to get HCM. Next slide. So how we define HCM? So based on actually my cardiologist, Dr. Mark Mahmoud, he was part of the research project. So I was not familiar with this coding, so he helped me to how to get HCM, because initially I used just like a ICM 10 142, but he told me, no, you can use other code like ICD-9, ICD. So SC is that include obstetric cardiomyopathy, hypertrophic cardiomyopathy, cardiomegaly, code ICD-9, Then we use standard obstructive hypertrophic cardiomyopathy, ICD-10 142.1, and other hypertrophic cardiomyopathy, ICD CM 10 CM 142.2. So together, after coding all of this, then we extract ACM, and that is total 11,432 patients. Okay, next slide. And then as our focus is social determinants of health, so we merge our electronic health record data from survey data. That I think that data are from population-based data from ACS, American Community Survey data. Okay, next slide. So this is when you run the analysis. So we use as a on cloud-based Jupyter Notebook from the research workbench. You have other options now. You can use SAS, and also you can use R. I think so. I think also I'm not sure about SPSS. They initiate. I think they maybe started to use SPSS too. So I did simple analysis for like a look at the some independent sample t-test on sample size low, manuality test for continuous variable, and also for cross tab I use chi-square test for categorical variables and look at black and white patient and like a looking some clinical outcome. And also standard two-sided p-value less than 0.05 was considered to be statistically significant. Next slide, please. So we found among 11,132 patients, look at the, if we want to look at the distribution, it looks surprised me. Look at white males, 54%, and white female, 46%. But when you look at the black males, 35%, black females, 65% patient. Next slide. So this is another way if we look at the how it looks like the distribution by race ethnicity among HCM patients. So we found that black females have more, and also white male. So distribution is different. The next slide. And that is very interesting. If you look at the age distribution, and we can see that if we look at the white and black patient, we look at black African American patients develop ACM earlier than white patients. Next slide. And now if you look at the social determinants of health, so if you look at this is from, it's called American Community Survey, and most of them are from population level data. So we look at some important variables there, like a fraction of population age 25 and older with educational attainment, at least high school graduation. We can see that black have lower education, and also if you look at the median household income, also showing black have lower median income. And also look at the household fraction receiving public assistance income or food stamps, that has more black patients receiving public assistance. And these all three are significant. And also fraction of population with income in the past 12 months below the poverty level. So we also find out black patients have higher. And fraction of the population with no health insurance is also showing black have lower health insurance. And they have another very interesting variable that's called deprivation index. They also calculated, and this is a composite score. So it also shows that black have more deprivation index compared to white patients, and is very significant. So that is calculated from ACS and composite score and using 3-digit zip code. Okay, next slide, please. Now, if you look at the clinical outcome, look at that is also surprising me. And so if you look at the hypertensive disorder, and it's using, I think it's called SNOMED code, it's a concept code, a standardized code. Using that code, we found hypertensive user are, look at the graph. The black have more patient and significantly higher number. And also, but very interesting, atrial fibrillation is showing white have more atrial fibrillation. And even mitral regurgitation also higher among white patients. But black patients have a congestive heart failure more, and also the embolic stroke, that is also, it's not showing significant, okay, we cannot say anything about that. And sudden cardiac death also showing higher among white patients. Next slide. Now, if you look at the comorbid conditions, so it's showing you sleep apnea. It's not showing no difference between black and white, but diabetes have more among black patients. Diabetes and chronic kidney disease also more among black patients, and also hyperthyroidism also more. Next slide, yes. And now that is disparity in management. If you look at this thing, in terms of the defibrillator or pacemaker, whatever is replacement of defibrillator or septal ejection therapy, all are higher but lower among black patients. That's the management. There is a disparity. But I know I changed the the number, make up 40 because all of us just said if it is a less than 20 number, don't need to disclose it. So because so that some people may be identify the patients. So that's why I make it up 40. But I know these are, and also I black it out. So that's the number is very low, but it's showing you there is a disparity in terms of management. So it may be due to insurance, or maybe we don't know, we have to explore it, or maybe that is the provider bias, either implicit or explicit bias. We need to explore these things. And also there is a small number of patients, so we have to, we don't know, there's a, maybe we have to look at the significantly different or not, we have to do some kind of advanced statistics. Okay, next slide, please. So what we found, so black patients develop ACM in younger age. That is interesting. And also we found that disparity exists between black and white hypertrophic cardiomyopathy patients. And we found that in terms of the comorbid conditions, in terms of the outcome, clinical outcome, in terms of the management, they have a disparity exists. Next slide. So that's why this is we have to look when clinicians should be aware of disparity in management of care among black patients, and also appropriate care is needed to address this disparity. Next slide. So my next goal is to, we know this is initial study, and when you look at the literature review, we saw that, and also it's a very common genetic disorder, 1 out of 500. So we have to look at the genome association study to investigate the genetic difference between black and white patients. And also we see that there's a difference between atrial fibrillation and there's a disparity higher among white patients. And also the heart failure are more common among black patients. So we are planning to do in future using AI machine learning approach to get the prediction model, actually to find out the prediction model for AI using AI machine learning, and also we need for using this approach, so we can later on see what intervention was, social intervention or biomedical intervention, to reduce disparity. That is our next goal. And also to detect whether they have a probability bias or not, either implicit or explicit. We have to work on it there too. Next slide, please. So actually, this is the main I got the it's called Leadership Fellowship from AI Machine Learning, AM Head from NIH through University of Houston, University of North Texas, and John Hopkins. They got the fund from NIH, and I luckily got opportunity to that's called Leadership Fellowship in AI Machine Learning. So I got that one. Then I think Dr. McNeil suddenly during the time called me, and I don't know how it she approached me do this. I'm saying, oh yeah, I'm using this one. So Dr. McNeil helped a lot to support also for doing all of us research because without maybe we not get access to all of us workbench. So she helped a lot, and she did this agreement and other stuff. So Dr. McNeil helped a lot. And also, as this is before I didn't use it, I need a lot of help from a lot of other sources like a Baylor Medical College, Train the Train Research Session, and also Research Academy, and Seven Star, and also sometime all of this work best. So though it's a new thing, new learning thing, because I never used before all of the serpents, so it takes time, but there's a lot of help. Anybody can use it, just going through office hour or train the trainer session. And also I saw email also there is still going on office hour from all of us research, so anybody can get that training and can use it. Next slide, please. Oh, now we have a Q&A, question and answer section, and also fire chat, right?
Absolutely.
Yes, okay.
Thank you, Dr. Bouillon and Dr. Idet. This is the time where any and all questions can be asked. Please feel free to put your questions or comments in the chat. And we will begin the session with a fireside chat between Doctors Idet and Bouillon. Thank you.
Sounds great. All right. I have a question. This is for you, Dr. Boyan. What surprised you the most about the differences in clinical outcomes between Black and white patients with HCM? And all of
Yeah.
us.
From the officer. That's the first thing we found it. Okay, that surprised me that even it's a genetic disorder, it's common, but we found that Black patients develop earlier. So that is one very important thing. And also, if you look at the complication outcome, clinical outcome, it's showing you the atrial fibrillation is more among white patients, but heart failure and the hepatitis disease are more common among Black patients. That is thing. But in terms of the if you will add other things like a comorbid conditions as like a defined, Black have a diabetes, Black has though sleep apnea is a common both Black and white, but it's different for disorder, hyperthyroidism. These are more among Black patients. Okay.
Uh-huh. And so is it right to say or assume that these underlying conditions, so be it diabetes or hypertension, maybe to some degree increase the risk for it, even if we know it's genetic? You think they have a part to play? Maybe exacerbating it, maybe worsening it over time?
Yeah, that may be because we saw this. This is like again, it's a I forget to tell you. This is a cross-sectional study. Though we see the association, but we cannot. So that's why I need to in the future explore using the longitudinal data. That's why we can get more answer, because this is just like a detailed plan cross-sectional study, because I was not used to before. So though I know all of this epidemiology method, but this is first time I use EHA data. So we just explore it and look at the using cross-sectional study, how it looks like. Yeah, in future, we have to go in different direction.
Sounds great. My second question is, given the findings, from the study, what changes would you recommend in clinical guidelines or medical education to better address the racial disparity gaps in HCM treatment and diagnosis and treatment?
Yeah, because though I think clinician should, when you look at this thing, I think if you look at in terms of the management, why Black receiving the uh, pacemaker or antifibrillator are less than in Black, actually. So it maybe, I don't know, we explore is maybe they don't have health insurance, because I have to look at health insurance status also. So maybe that's why I have to look at the or maybe it's due to provider bias. So we need to, they have to look at this thing, whether, and also how can we eliminate the provider bias. So that is also important. So we don't know, it's maybe implicit or explicit. We have no idea. So that
Yeah,
is,
I agree.
they look at. Mhm.
I agree. I think I would like to recommend that, for medical, in regards to medical education, so medical schools and also residency programs should prioritize or incorporate race-based trainings for their students and their residents to raise awareness about, these types of disparities, that exist, for example, with HCM. And hopefully with better awareness, we will have more people, that will be able to maybe identify it or prioritize it or report it more, and we'll take it even more seriously when it's being reported as a symptom among patients. So that
Yeah.
would be my recommendation.
Yeah, and also I think nowadays it's a lot of it's called implicit bias training. I think it has
Mhm.
now really become popular from Harvard University and other. They are now doing these things so that to eliminate implicit bias. They have a lot of training going on, but also in our graduate study also showing some how to do the idea about the implicit bias. I know sometimes explicit bias may not cannot avoid, but implicit bias is another factor.
Nice, thank you. I agree. Well, my next question. Yes, you had talked about future directions for the study. Are there some unanswered questions still, or maybe some gap in the literature that future studies could still explore?
Yeah, I think when I say this, because when you look at the race ethnicity, we are still, it's a maybe self-reported race ethnicity, or it's not a research assigned race. So there is still bias. So when you measure race ethnicity, because it's a self-reported. So that's why a lot of study recently, they talk about the ancestry, because there's a genetic base. So it maybe give you whether the ancestry study, because find out actually which race we belong to. So that is ancestry study is in the literature talking about. So I think all of us Workbench has a ancestry data, I think, that way we can link in future. And also we have a genome-wide association study. We can add genetic data, so we can link with the genetic data and we can explore these things. So because we can find the which genes are more, though in literature they're talking about some genes, sarcomere genes and other particular genes are involved, but we can explore this thing using all of us data. So that is also we can do this thing.
Dr. Idet and Dr. Bouyan, I have a question that is related, and it is, in what ways can the All of Us research program continue to support equitable precision medicine approaches for underrepresented or minoritized groups?
Yeah, that's a good question. I think that's all of us research is going to precision medicine approach because like they are. I think this is the most represented population from diverse population, like a 45% from minority, and also sometimes sometimes it's showing 80% from underrepresented population. So if we use all of us data and it becomes so popular because that's why it's the diverse population. So one size instead of one size fits all approach, so we can go to precision model approach because looking because everyone is different. So in terms of the geographic location, in terms of the food habits, in terms of the behavior factors. So that's why all of us is try to approach precision medicine episode because collect all of individual and their target is I think 1 million. It's almost 70,000 participants already. So it's going in the right direction. I saw if you look at the trend, this increase day by day, day by year. So it increased a lot questions. And also all of us users has the advantage. You can not only use electronic health record data, you can also merge with the Fitbit data and a lot of study you can do it using. That's why it helped a lot, all of us research departments.
Thank you. I see that someone has their hand raised, and I've asked them to please put their questions in the chat so that we can respond to them. In the meantime, I will ask Dr. Idet if she has any other questions for you, Dr. Bouillon, as we continue the fireside chat.
I do not have any further questions.
Then I will move forward with a question that I have, and that is, how can clinicians and researchers work together to translate findings from big data into real-time, individualized patient care for HCM? And this might be, related to precision medicine as well. Thank you.
Yeah. Thank you. That's a good thing. Not only, I think nowadays, notice you cannot do this in silos. So everybody, because if I do, like, for example, when I try to do literature review and try to find out how to get ACM, I only get, I think, 1,000 only instead of 11,000 because I don't know how to extract the ACM from ICD-9 and 10 code and even ICD-10 code. But when my collaborator, researcher, a cardiologist, so he find it out. Oh, no, 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 not that way. You have to do these things. So without him, I cannot make it nice sample size. So that is a collaboration. And also there's a researcher and the clinicians should work together. So sometimes whatever for the interpretation or the as a clinical, we can statistically say the significant, but it is meaningful or not, clinician can give the idea, no, it's clinically significant or not, though it's statistically significant. Then not only this one, and also to translate these findings in the community, we need like you, like research academy, like the CCPA, so that can help to translate our finding. And also CBPR local, so we can translate this finding to community. So that is the we in triangle, it help a lot, clinician, researcher in academia, and also community. So that way it help a lot to translate finding and to get with the clinician to understand this thing. A lot of issue when we use the EHR data or any health data, we need uh, clinicians in our board. That's the main thing.
Thank you. We have a question. In what way can we use all of us in nursing education? And this is for both of you.
Mm-hmm.
Well, I would say nursing education, it's still very much similar to medical education, right? It all boils down to, practice, clinical practice, improving patient health, right? So in nursing education, again, bringing awareness to the condition if in the nursing education curriculum there is an aspect of research, work, conducting research, then nursing programs can provide access to the all of us data, provide that access to the students, where they can get better hands-on practice on how to use the data, and with them being more acquainted with how to conduct research and use national representative data sets, so complex sampling methods and all that. When they're able to conduct those kinds of research, and they can learn about findings, what's the data telling us, and based on that develop or design big clinical interventions or other public health interventions to address disparities. So that'll be my response.
Yeah, I agree with Edith also. Yeah, we are public health, nursing, all are doing research for the contribution to the community. That's the main goal. Everyone's trying to improve health. That's the main goal. Everyone is.
Yeah, I was just going to chime in on that as well. There are a number of faculty members that are incorporating all of us into their curricula for their students. There's the public data browser that people can access. It's very high level data, so you actually don't have to be registered to access that data, where some simple analyses can be done, but then other analyses that do require registration, there are faculty members in public health and also in nursing that we know of it through the Researcher Academy that work with students. So it certainly can be used to analyze a lot of different, various different conditions and influencing factors.
Thank you, Dr. Hood. Final question is, looking forward, how might machine learning or genome-wide studies help us move from recognizing disparities to actively preventing poor outcomes in HCM?
Yeah, because nowadays AI machine learning become popular in healthcare setting and healthcare research, because actually I'm learning this thing last 3 years. So before I has no idea, nothing. Just after COVID, I learned when COVID happened. So we are learning data science thing through Harvard University and other. Suddenly we saw through email starting learning it, and I saw they have a advantage some kind because they can handle like if missing value nicely properly. They have defined imputation technique, AI machine learning they can use, and also they standardized before applying AI machine learning methods. They can use standardize the data, like convert different variables, string variable to numeric variable, and so I think they have do the different process like before applying methods. So that is, I think, it's a beauty. And also that's why, and also AI machine learning can handle big data. So that's also is a good. So that's why I think AI machine learning, and though they have some ethical issue, and also algorithm bias, and also the ethical issue. So I think if we solve this thing, AI machine learning can give you better prediction, and also other aspect of the outcome variable. So whatever you want to do, I think it help a lot in future. Yeah, machine learning, and if it become trustworthy.
Thank you very much. We are coming to a close. We are not done yet, though. But I do want to take this opportunity to thank Doctors Bhuyan, Hood, and Idet for this insightful presentation. And what I'd like to do now is for you all to take just a few moments to please fill out the evaluation survey. Just take a few moments. And I'm also going to put the link in the chat, but you should be able to use both the QR code and the link. Please just take a few moments to fill out the survey. Thank you. Thank you again so much. I appreciate you taking the time. I want to thank everyone who has attended our final webinar. I'd also like to thank, of course, all of the presenters, but I'd like to thank the institutional champion at Jackson State University, Dr. Cassandra McNeil. She has been a supporter throughout the process and in the all of us work that we have done. Thank you all for attending. Thank you all for your support. And I look forward to working with you and seeing you all as we continue to try to improve health outcomes in minoritized and under-resourced communities. Thank you and enjoy your afternoon.
Thank you.